Good afternoon, everybody. I'll be speaking on color matters. Basically, I'll be speaking on the yellow laser and mainly the subthreshold part. So laser, as we all know, it has been the standard of care for several retinal disorders, and the pigment involved are xanthophylls within the neurosensory retina, melanin within the RP and choroidal melanocytes, and hemoglobin within the red blood cells. The recent developments, I think we have already gone through. From the single spot, we have gone to the pattern scan, and now we have come to the micropulse mode. I'll skip this slide. So 577, it was previously available on dye lasers. It was a large machine and it cost a lot. But that's why it was not used after 1990 due to expense and the competition from cheaper 532 lasers. It has become affordable now and hence has made a comeback. So there's a new interest in 577 laser. So basically it has a longer wavelength. The further you move in the longer wavelength part of the spectrum, the better the laser will pass easily through the cataract. And it has some very desirable properties. I'll just go through that. So there's a good absorption by the oxyhemoglobin and melanin, very low absorption by macular xanthophyll. So that's how you can come closer to the fovea, low light scattering, and you need low power to achieve treatment endpoints, and it's less painful for the patient. So this is the traditional treatment sometimes we see. So that is not the ideal way to do laser. Such patients will have contrast, night vision problems, and if you give a lot of burns, you will get choroidal detachment, exudative detachment, and multiple sessions were required. And if you are near the posterior pole, you can create a CNVM, subretinal fibrosis, scotoma. So all this we are seeing less because of the multi-spot laser. Here the duration is very less. It is just 10 to 20 milliseconds. And with a single foot pedal press, you can get multiple spots. So the barely visible 10 millisecond burns produce an effect at the level of the ISOS and apical RP with minimal axial and lateral spread. So that's why the burns are very fine, pinpoint, and the axial lateral collateral damage is less. And patients prefer multi-spot laser. So a lot of studies have shown that. So are we doing laser correctly? Historically, we shot the red dots. So do we really have to destroy the retina? So the new thinking is that we should stimulate the RP to change the microenvironment. And this will allow the anti-angiogenic factors into the inner retina photoreceptor complex. And so the target should be the RP and not the retina. And this can be best achieved by micropulse laser. So what happens is micropulse laser, and why we are interested is we want to localize the thermal effect to the RP. And for this exposure of 0.7 milliseconds is required, which is not possible by the continuous wave laser. This is only possible if we chop the laser wave into micropulses. So here the laser energy is dispensed in an envelope of micropulses, and these summate to cause activation of cytokine expression and upregulation of matrix, MMP, and VEGF down regulation. So this is how it is chopped. So this slide is important. So basically what it shows is that if you give a conventional laser, so the red and yellow zone, there is immediate and latent necrosis. So this retina is destroyed. So it is not useful. So we are interested in the green zone, because the green zone, the retina is treated, but it is still viable. And these viable cells will release stress response. And this non-lethal energy in still viable cells causes stress response. And this leads to change in the microenvironment. So when you do a sub-threshold micropulse laser, there is a larger area of cells or the part of the retina that is still viable. So this is a case of DME, 61-year-old female, type 2 diabetic, hypertensive, uncontrolled. The vision in both the eyes is 6/6 and 6, and fundus examination shows mild NPDR, both eyes. Could not appreciate CSME on slit lamp, but here if you see the OCT shows a fine pocket of edema fluid. So such patients, what to do? The options are, you can wait and watch. Conventional laser is just not possible. What about intravitreal injection? It's also risky with 6/6 vision. There's always a possibility of infection. So what else can be done? So this patient underwent micropulse yellow laser, and this is at the 6 months. So you can actually treat across the fovea with the micropulse laser. So this is an option in patients who have just foveal involved edema. So safety of transfoveal subthreshold diode micropulse laser has been shown in this study. So they studied the safety of transfoveal SDM for fovea involving DME. 39 eyes were there, and the pre-op vision was 20 by 20 in 10 patients, 20 by 25. So basically all the patients had very good vision. And they underwent SDM, and no eye had any retinal damage. The CMT improved gradually, and the logMAR visual acuity improved on an average of 0.03 units. So to conclude, transfoveal SDM was safe and effective in the treatment of fovea involving DME. And we were the first ones to show that subthreshold micropulse yellow laser is effective in chronic central serous retinopathy. So this was the study that we published, and we assessed the safety and efficacy of a single session of subthreshold yellow laser in the treatment of chronic CSCR. 15 eyes were treated, and all eyes had chronic CSCR. And reduction in subretinal fluid height on OCT was used to measure the response to treatment. So the results for the mean follow-up was 8 weeks. The mean SRF height pre and post treatment was 232 and 49 microns. So there was statistical improvement on SRF, and there was no evidence of RP or retinal damage on OCT, FFA or FAF. So this is one case, 45-year-old male, no systemic complaints, non-smoker, blurred vision since 2 weeks, 6/9 vision. You can see the typical smoke stack pattern. And one thing, the treatment that we based was on the ICGA. So if you do FFA, you just find a pinpoint leak. But if you do ICG, then you see that the problem is a little more widespread. The choroid is more hyperpermeable, hyperdynamic, more congested in a wider area. So if you have to plan treatment with micropulse, it's better that you treat it based on the ICG. So this patient also underwent micropulse laser, and within 3 weeks there was good improvement. And we have used it for BRVO also. So 21 patients, average age was 61. So basically, micropulse is an evolving technology, so which has its uses, but it has some limitations also. So basically, it's like that there's a plenty of water, but you cannot drink every water. The same way, plenty of lasers are there. So you have to choose the right laser, right technique to employ so that you give the best to your patients. I think to conclude, I'll say that limitations of micropulse are there, that there is no visible endpoints. If we could get a test to really see what we are doing, the burns that we are getting, it could be good. Till that time, we have to rely more on the tests like OCT, microperimetry, to see what is the response, because microperimetry, OCT should show some changes within 2 to 3 weeks. If you wait for the vision, it will take a pretty long time. So we have to rely on such tests to see the efficacy of our treatment. Thanks.